Welcome to Women in Healthcare Leadership podcast series brought to you by Medscape Education. Our goal is to provide a platform where we can educate, advocate, and inspire women leaders to lift as they rise. With every episode, you'll hear from her as we showcase the perspectives, insights, and experiences of women who are leading the way in advancing women's health and empowering the next generation of women in healthcare.
Welcome to our second season of our Hear From Her, Women in Healthcare Leadership podcast series. My name is Yelena Spiropoulos, and I'm the Vice President of Education at Medscape. I have the privilege to have with me today two outstanding panelists. First, I want to introduce Sarah Jarvis, who is a general practitioner by trade, clinical consultant, and visiting professor of general practice in the UK. So welcome, Sarah. It's a pleasure to have you today.
Wonderful to be with you.
And also with me, I have Bharati Shivalkar, who is the Senior Medical Director for Rare Cardiology at Pfizer, but also a practicing consultant cardiologist at Delta Hospital in Brussels in Belgium. Welcome.
Well, happy to be here. Thank you for having me.
So it's really my privilege to discuss so many great topics with you today. But before we get into some of the challenges in healthcare specific to women, I wanted to ask both of you, and maybe we can start with you, Sarah, first. Can you comment on what really prompted you to enter a career in the field of medicine? And what prompted your interest, or sparked your interest in particularly the challenges related to women's health?
Well, I've wanted to be a GP for a very long time. I first decided at the age of either 7 or 8, I might worked which, sometime round about then, that I wanted to be a GP, not a doctor, but a GP. So the GP, he, because they almost all were he's in those days, gave my father an injection. And very, very incorrectly these days, he gave me, as a fascinated 8-year-old, the needle and syringe to, quote, play with afterwards. So I became fascinated. I started injecting my teddy bear with Ribena, and I kept the needle very carefully in a cork. For the first time in my life, I'd seen somebody who genuinely made a difference. I was absolutely overawed by this figure, this almost mythical figure, it seemed, who came and made my daddy better. And from then on, I've never wavered. I went all the way through Cambridge and Oxford, always wanting to be a GP. I just had to keep it a little bit quiet when I was there, because the feeling there was, at Cambridge and Oxford, we train professors. We don't train GPs. So I then became a GP in 1990, and at that time, we were very much in a minority. My experience, many of my colleagues said, well, there's 5 doctors in the practice, 5 partners. They have 1 female doctor. She might be a partner, or more likely, she'll be a sort of retained doctor who only does a couple of sessions a week. And she's there to deal with all the ladies' bits. And it very much felt like that at the time. So through the Royal College of GPs, with whom I was working very closely at the time, because I'd become the trainee representative on the RCGP Council, we did a survey, and I became a founding member and then chair of the Women's Task Force. And we were looking at the experiences specifically of women in general practice, so women doctors. And the reason that we set it up was because at the time, we asked as part of this survey, what are the biggest barriers to you for the obstruction of your career fulfillment? And for women, by far the most common comment was the problem with balancing home and work. And not one man in all of the survey even mentioned it, which said a lot to me. I then went on and became the women's health spokesperson for the Royal College of GPs, and I've worked in the media, predominantly the BBC, for almost 30 years. So I've spent a lot of time commenting on women's issues in the media, and I'm very conscious that they are dealt with very differently often from the way that men's health or issues that affect both sexes are dealt with.
So many great points you made there, and I am really want to get into a lot of that. But before we get there, I wanted to go back to Bharati and just get her personal experience about, what prompted her to really enter the field of cardiology in her case. And I think there's going to be a lot of similarities there.
Well, actually, I decided to do medicine early on, but it was somewhat later than Sarah. So I think I was about 11. I grew up in London and ended up in Belgium really just by chance. I've done most of my medical training in Belgium, and the major part of my professional life as a cardiologist has been in academia as a professor of cardiology and an imaging specialist with a huge interest in early detection of cardiovascular disease in different disease domains. And my interest in women's heart health really grew in stages. So first, as a young cardiology fellow during my training in the echo lab, I found that the thickened heart muscle in the small heart cavity on the ultrasound was such a regular finding in older women. And I wondered why. And I also wondered if my heart would look the same when I was 80 years old. And then gradually I understood that this was most probably the result of underdiagnosed, untreated or undertreated hypertension and some other risk factors. And indeed, with all the other complications that follow in women, such as HFpEF, heart failure with preserved ejection fractions, and stroke, which are indeed highly prevalent in women after a certain age. And then later on, when I was working as a consultant cardiologist, a young woman with rheumatoid arthritis was referred to me by her rheumatologist because of intermittent chest pain. And I recall his notes very clearly. He referred to that as atypical chest pain, but he also mentioned shortness of breath there. So the young woman also had a family history of Fragile coronary artery disease. I did obviously all the workup, all non-invasive workup, put her on medical treatment and followed her up. Now, the young woman did not receive immediate treatment, but within a few years, she needed stents. She had to be stented due to progressive disease and despite optimal medical treatment. So, that was kind of a revelation for me that given a combination of risk factors, and in this case, rheumatoid arthritis, autoimmune disease, rheumatoid arthritis with a low-grade inflammation in her body, and the family history can cause significant cardiovascular disease in young women as well. And then I'd also like to share the story of my own mother. So my mother would have had a heart attack at the age of 65. And that's young. I'd say that she had an exemplary lifestyle. She was very particular about diet, etc. And she was sensitized to that because of my father, who had diabetes from an early age. And I noticed shortness of breath walking up the stairs when she visited me in Belgium. And she went back home to London with her first coronary stent. Now, these problems do not arise from one day to the other. So plaque formation is a long process, a progression of which can be halted or slowed down with timely intervention. And I should add here that my mother had a very strong history of premature coronary artery disease in her family, which had affected mainly her brothers at a very young age. But she, with her exemplary lifestyle and without any other risk factors, managed to not have any problems till her mid-60s. So I just wanted to highlight the difference between the young woman with rheumatoid arthritis and my mother in her 60s. And then, as my interest in heart health deepened, I felt very strongly about it, and I've spoken about women's heart health issues primarily all over Belgium. I was on the board of the cardiology league called Cardio Liga, which is, I suppose, the British Heart Foundation equivalent in Belgium. I was on their board for some years with the aim of creating awareness around women's heart health matters. I also started the first women's heart clinic at the University Hospital in Antwerp several years ago. And this was in collaboration with the Department of Obs and Gynae. And so that was the first multidisciplinary collaboration where I saw middle-aged women who had suspect complaints that were beyond what one may call the standard menopause-related complaints, and younger women with pregnancy-related complications such as preeclampsia, eclampsia, gestational diabetes that are known to develop cardiovascular problems at younger age. So when I talk about that time, 3 cases come to my mind in particular of women with menopause-related complaints who in fact needed stents, coronary stents. So, I want to finish up my story here by, I don't want to give the impression that, and I don't want to say that all menopause-related symptoms translate into cardiovascular symptoms. No. But it is important to listen carefully to the complaints of the patients and to put them in proper context to be able to treat patients optimally.
I couldn't agree more. And I think this is a great segue into some of the work that I know, Sarah, you also have been, doing in the UK. I know you've been involved in a number of different initiatives, including the women's health strategy, as well as many others. So can you comment on your experience and the importance of exactly what Bharati just said about, using appropriate, preventative strategy, knowing your numbers, really focusing on that holistic approach when it comes to health, especially for women?
I couldn't agree with you more, and it's wonderful to hear all the work that Bharati has been doing. I wish I could take credit for the UK women's health strategy, but actually it's a government initiative. However, I was involved in interviewing the health secretary and trying to raise awareness. And in 2021, basically the UK government sent out a request for submissions and received over 100,000 of them. And there were three key themes which came out. They were, where women was concerned, firstly, taboo and stigmas. Secondly, feeling listened to by healthcare professionals. And thirdly, women's voices within the healthcare system. Now, if we think about some of those elements, I think we get a real idea of where some of the gaps remain. Some of them are in female-specific conditions. So, for instance, endometriosis. On average, it takes 7.5 years to be diagnosed. And that is quite simply unacceptable. And dare I say it, if this was a condition which affected predominantly men, I think that it would long ago have been considered totally unacceptable and something would have been done about it. But then if we can consider, say, well, for instance, myocardial infarction, heart attack, as Bharati has mentioned, the simple fact of the matter is that women are up to twice as likely to be misdiagnosed when they have a heart attack, according to a University of Leeds study. And I'm sure that Bharati's research shows the same thing. Osteoporosis doesn't only affect women, but it predominantly affects women. Half of women over 50, compared to 1/5 of men over 50, will fracture a bone as a result of osteoporosis. And yet, despite the fact that there are clear preventive strategies we can take, there is no national screening program for osteoporosis in the United Kingdom. The newer osteoanabolic drugs are confined almost exclusively to secondary prevention. In other words, you kind of wait for failure. Or you can have one of these drugs which will help you to rebuild your bone, but not until you've fractured at least 2 vertebrae, which is almost certainly going to leave you in chronic pain for the rest of your life and may affect even your ability to breathe. Hysteroscopy, another very good example. That is, of course, a female-only procedure, but it's very similar, I would suggest, in terms of invasiveness to, say, colonoscopy or endoscopy. And for those, sedation or analgesia is routinely given. Yet in the UK, NHS targets are for 90% of those procedures to be done without any medication, without any sedation, without any analgesia. I find that completely unacceptable when you think of the similar conditions, which are done on both men and women. Then if we come to pain, now pain is a really, really big one. Again, in the UK government's women's health strategy, half of women who replied, that's 50,000 women out of 100,000 who replied, said that they felt their pain was ignored and or dismissed by healthcare professionals. Now, that's not just the healthcare professionals' fault. I think it's largely to do with society. There was a fascinating study in 2021 where Amanda Williams from University College London asked men and women to watch video clips of patients of both sexes undergoing painful examinations. And compared to the patient's own rating of their own discomfort, observers consistently underestimated women's pain and overestimated men's pain. So I think that's a really good example of where perhaps society as a whole plays a part in this. The assumption is that women just, are always going on about pain, so they perhaps overestimate it, they dramatize it. And of course, research is another area that we really can't ignore. We know that, for instance, whether it's cardiovascular disease, hypertension, many areas, the participants are often overrepresented among men, in other words, underrepresented among females. So we don't necessarily know whether treatments will apply to both men and women.
Yeah. Again, I think so many great points you brought up from your own experience as a GP. And in just listening to your words and what you were saying, I wanted to go back to Bharati for a second, because your very last point reminded me of something that Bharati mentioned to both of us. I don't know if you remember, when we were discussing this podcast in our planning stages. And Bharati, you mentioned, for example, heart failure being a good example, where many women are still treated like a small man, right? Due to many different factors, right? Due to the lack of representation in clinical trials, due to different, biases there. So can you comment from your experience too?
Yeah. This obviously many biological and behavioral differences in men and women, but the understanding of many diseases and different diseases is really based on their male-centric models. So our understanding of diseases and the care pathways are really based on studies that were done in men. Traditional understanding of disease is focused primarily on the male body. And so, there's been very limited representation of women in clinical trials. So the treatments and the guidelines are based on the findings as men. So women often get treated only once they have reached a certain threshold of disease that is the same as that in a man. And so this is what I meant by a woman being, treated as if she's a small man, despite the obvious differences in a woman's body with the, just if you just focus on the heart, so differences in coronary anatomy and physiology, the different hormonal effects, the different bone and the muscle mass, and everything else. Women are still considered primarily because of those. Our understanding of almost every disease is based in studies done in men. And you can also realize from everything that I've said now regarding the differences in the anatomy and physiology, etc., that for a given threshold, for a given burden of a disease, that a woman's body is going to suffer much more than a man. And so by the time a female reaches that a given care pathway, the problem has progressed to a much greater degree. She's much worse off than a man might be presenting a disease. So that was the point about the woman being treated as if she's a small man. And what I'd also like to share is even more distressing statistics than what Shara just said regarding heart attacks. Women are actually up to 7 times more likely than men to have a heart condition misdiagnosed or discharged during a heart attack. Now, the reason for that being that the complaints and the presentations are different. For example, women may not present themselves with the classic, the Hollywood heart attack where someone grabs their chest and falls to the floor, or not present with the typical classic medical textbook descriptions of heart attacks. These have been really the causes. I mean, we know that 1 in 3 women are dying of cardiovascular disease, which is a fact which is sadly enough not known, even amongst healthcare professionals, let alone women, let alone as society at large. So these are some of the shocking facts that we are faced with. And then on top of that, of course, there are also gender norms that are created, which can influence the lifestyle and dietary habits, attitude towards prevention, and stress coping mechanism, which also affect women very differently to men.
Yeah, and I think I couldn't agree more with everything you just said. And look, I think the very first goal of our podcast here is to raise awareness of these issues, because as you just pointed out, many even healthcare professionals are not aware of these statistics, and the same definitely holds true of the general public. But in addition to raising awareness and discussing these issues, I also wanted to spend a minute discussing some practical solutions and strategies that could be implemented to improve all of these challenges we just discussed. So I wanted to go back to you, Sarah, because you have worked as a GP for many years. I'm sure you've seen things that have worked better than others. So what has worked well, and what can we do to improve the situation?
Well, I'm really glad you asked that, because I've been training other GPs for 25 years. So what we have in general practice is a one-to-one relationship between the GP trainee, who is a qualified doctor, and the GP registrar, as we sometimes call them, and their trainer. And an awful lot of time is spent on what I get very cross because it's often described as, quote, soft skills, by which we mean communication skills. Now, I don't think communication skills are a soft skill. I think they're an absolutely crucial skill. If we look at, for instance, the terminology that we use, there was a 2018 study, as recently as 2018, it analyzed journals, papers on sex, gender, and pain that have been published in right across the world, the UK, the US, and Europe since 2001. And it revealed that doctors were much more likely to apply words like sensitive, malingering, complaining, even hysterical, than they were to apply those same words to pain reports from men. So I think that perhaps is the first thing. I think the second thing is that we have come a very long way in general practice in terms of training. We're getting there very, very slowly for medical students, but it's a very long process. And of course, part of the problem is that once you get to your hospital jobs, dare I say it, you are often supervised by doctors who've had little or no training in communication skills. Now, when I talk about communication skills, for instance, shared decision-making, I think is absolutely key. It's gained real traction in the UK in theory and indeed across the world. I think a lot of people now worldwide are talking about shared decision-making, which in theory is basically you integrate the best available evidence, the clinician experience, and the patient's values and preferences. And what we're saying there is, look, I am the one with the degree, I am the one with the medical knowledge, but you are the one with the lived experience of this condition. So both our perspectives are equally valid. My job is to help you become informed on the facts, to help you to develop what your preferences are for the options that are available. And shared decision-making is about looking at a smorgasbord, if you like, of available options and helping the patient to come to a decision which works best for them. But basically, the ultimate decision is the patient's, and it has to be an equal decision. It has to be an open discussion. We integrate the medical issues at hand, their preferences, their contexts. If I have two patients come into me, they may have very different priorities depending on what else is going on in their lives. If I don't know that, and if I don't respect that, then they are much less likely to get the treatment that A, they need, and B, they are likely to stick with. So basically, the final decision is up to the patient, but collaboration with the clinician. And I think it's got to be about collaboration. We know that it benefits society because it reduces healthcare costs. We know that it benefits the patient. Well, yeah, fairly obvious, that one, because, it actually, if you look at objective markers like adherence, then it improves that. But it also actually helps benefit the doctor. A lot of the doctors that I teach about this will go, but doesn't it take an awful lot of time? Well, yeah, in the short term, but actually, we're helping drive informed patients. We're reducing the risk of complications. The patient, is more likely to comply, so they're less likely to come back later with complications. And that will reduce workload for us in the longer term.
Absolutely. And I think some of those challenges and issues are very, very important for women too, because we all know that women very often take care of entire families. They take care of their kids. They take care of their parents, and sometimes they forget to advocate for themselves. I also wanted to, bring that back to something that Bharati said earlier, that collaboration, because I know you mentioned it, you yourself have started, Women's essentially Heart Clinic, and that you collaborated successfully with the OBGYN teams. And I think that's very important because very often women use their OBGYN essentially as a primary care physician. So can you comment on your experience and the importance of collaboration, Anne?
Yes, certainly. Now, what's actually important to understand is that women's health issues are not just menstruation, fertility, and menopause related. And there are many sex-specific and sex-related health issues that may eventually cause cardiovascular disease, which takes a huge toll not only on the individual, but society at large. As we said before, it's killing 1 in 3 women, which is a sad fact. If you look at the total global women's health burden, this is hugely concerning. And it shows that, and these are really very recent data, that 43% are conditions that affect neither women disproportionately nor differently. So, for example, ischemic heart disease and tuberculosis, 43%. 47% affect women disproportionately. And I'm referring here to autoimmune diseases such as rheumatoid arthritis and also migraines, headaches. And only 5% are actually women-specific conditions, that is fertility-related and gynecological conditions. So just these facts, just these figures show how important it is to have different disciplines, different specialists looking at women's issues and working together to provide a life course of care for women, which goes beyond the care for sexual and reproductive health. And what another important fact to remember is that almost 50% of this burden that we're talking about affects women of working age. So helping these women improve their lives and their life conditions lives is obviously going to have an impact on society at large, socio-economic impact. It causes a ripple effect on communities. Improving a woman's health causes a ripple effect on the communities, families, the communities, and nations. And I have to think of first manifesto on women's health that was produced by the EIWH, European Institute of Women's Health, in 2018. And it was called Healthy Women, Healthy Europe. And I think that summarizes it beautifully. So we have to keep that in mind. Women make up for 50%, half, and in some countries just over half of the population. So it's important to develop multidisciplinary care models to provide a life course of care. And I truly believe, and I'm a big proponent of that primary care remains a cornerstone of providing that care.
Absolutely. And I also think, you both mentioned something very, very important, and that is that healthcare professionals obviously play a very, very important role. They have the tools, and their job is to offer appropriate guidance. But at the end of the day, this is all about women. I'm going to say patient-centered care, but we coined this term where we're calling it women-centered care. So how can we ensure that also patients themselves, women, are receiving appropriate education and then also tools and resources to really put them front and center and to really ensure that they're also advocating for their own care? I don't know, Sarah, if you wanted to comment on that.
Absolutely. And I'm so glad that Bharati has brought up not just menstrual and gynecological problems, because it absolutely extends much further than that. As she so rightly says, I spend a lot of time in the media talking about the fact that many autoimmune conditions affect women disproportionately. But we do need to bear in mind that women do need care in their reproductive years and so on. So, for instance, if we look at what the UK Women's Health Strategy's priorities are for 2024, actually some of them are really, really laudable. They are looking at women's health hubs. Now, that's not just for menstrual and gynecological problems, but it does include those. But, that, for instance, they may, I hope, reduce the waiting times for endometriosis. They may promote easier access to contraception. Many of those things will play a vital role in managing quality of life, as well as just problems, as well as just the pain involved. It's also, as Bharati says, going to mean that we have more productive women. And these days, women have never been more busy than ever. They've always done the vast majority of the child rearing, the home care. Now they're the squeezed middle. They've got elderly parents and young children who are dependent on them, boomerang children who've left for university and have now come back again. And at the same time, all too often, they're trying to hold down a full-time job as well. So we really need to help those women at every stage. So I think, those women's health hubs, I hope, will help. But we also need to help to tackle disparities. Because, the three of us, frankly, if we had a problem, when I was diagnosed with severe osteoporosis, I knew what I wanted, I had the science, and I was able to advocate for myself. And yet the DEXA scan result that I got really suggested that the treatment I needed was something that I knew simply was going to be tinkering at the edges, given the severity of my condition. So I was able to advocate for myself. And I really want women to be in the position that they can do that too. But we need to think about vulnerable women, victims of sexual abuse, victims of violence. We need to make sure that staff are trained so that they understand that their priorities and their way of accessing healthcare may be very, very different. Women in the justice system, another very good example. How do we ensure that actually they're not just deprived of their liberty, but that they are not deprived of the ability to access healthcare when they need it? Maternity care, of course, we need to think about. And of course, that needs to be safety before, during, and after delivery. But we also need to bear in mind, again, disparities looking at different parts of the country. We know that outcomes among different ethnic minorities are very, very different. So I think the answer is that what we need to do is to work together with multidisciplinary teams, which in some cases may be an OBGYN with a family doctor, in another case, maybe a cardiologist working with a family doctor or an OBGYN, but in other areas, maybe, for instance, social services or the justice services working with the healthcare services. And only once it's all joined up and we are all aware of internal bias, we are all aware that we need to take these aspects of a patient's life into consideration, are we really going to make a change?
Yeah, and I love how you phrase that, because it is, by phrasing it this way, it becomes a really positive narrative. And I wanted to sort of end on a positive note. So I wanted to also just briefly discuss, so what do you think the future holds? What are some of the things that you're excited about? And what are some of the big improvements that we see today and perhaps are on the horizon tomorrow? So, Bharati, I don't know if you want to comment first.
Well, I think there's some exciting advances. There are certainly, when you consider women's health, there are certain strong movements in certain domains to create equitable and women-centric care that involves a multitude of stakeholders, just as Sarah was saying, to address the healthcare gap. And here I'm referring to women-centered cancer care that focuses on the unique needs of women in cancer treatment. And there was recently a paper from the Lancet Commission, and there was a call from there on advancing this women-centric cancer care approach that was published last year. So I think that's really a very exciting movement that has started. Unfortunately, something similar has not taken shape, or not very much shape, I should say, regarding cardiovascular disease. That's another point. And I think what should be mentioned during this podcast is the World Economic Forum that took place in January of this year in Davos, where they really talk about, they emphasize the importance of redesigning healthcare for women, with women in mind, and addressing the healthcare gap, because this is obviously going to create huge societal economic benefits. So, there's talk about creating $1 trillion business, or generating $1 trillion businesses through improving women's health. When you put it in terms of economics, I think you get more attention. So let's hope this is going to be paid more attention to. And what I'd also like to add to that is that there's also been recently more call for investments in women's health research. This is getting more attention. There was also some recent papers that I read produced by WAN, Women Health Access Matters, and there they considered 3 diseases, autoimmune diseases, brain issues, Alzheimer's disease, and cardiovascular disease, where they showed that, it's data-driven evidence really, where they showed by addressing these matters in a correct way, that there would be, again, huge global economic impact, positive impact. So let's hope that this is going to be attractive for everyone, and that is going to draw a lot more attention, and that women are going to benefit, and the society at large is going to benefit from that.
Yeah. And, I'm glad you mentioned some of the government and policy work that's taken place. I'm sure you're both aware that there's now a new White House initiative in the US on women's health research. And, it's a brand new initiative that was just launched last year that is hopefully also going to open doors, open more funding for more research and more initiatives dedicated to women. So that also gives me great hope. And what about you, Sarah? Any parting words that you'd like our listeners to hear from you?
I do think there is much positive out there. I think none of it, however, is going to work if we don't change our fundamental attitudes, whether it's attitudes towards women's pain or other entirely female or predominantly female issues. I think that having national initiatives, for instance, in the UK, we now have national guidance for every specialty on shared decision-making, on making the patient an equal partner. That's increasingly gaining traction in countries across the world. The patient as partner, the patient as advocate for their own health, the patient as expert. And I think that can only be a good thing. In order to have that, we have to have literature, health literature, which is appropriate to every woman, not just to the highly articulate, well-educated woman. But one area that I think we haven't touched on, just very briefly, we hear a lot of negative about social media. But let's give you an example in the UK. Of course, I'm sure we're very much aware of the vaginal mesh and all the complications that many women have suffered. In the past, I cannot conceive that any women's group would have been able to get together and make a real difference, to influence government policy, to make a real difference to the outcomes of women across the country. And social media, Sling the Mesh, did exactly that. So while there are downsides, I think there are very much some positives too.
I could not agree more. Bharati, I know you wanted to comment as well.
Yes, I'd like to just make a rather philosophical statement before we finish. I think addressing this gap in women's healthcare and achieving health equity should be a societal it's a moral imperative. And diseases are not fought in silos, and women's health is not a standalone issue. So there has to be a collaborative effort for education as well, not just for healthcare professionals, and continued education as we gather more and more data, as there's more and more investments being made into, as we hope that more investments will be made into women's research, but also education of women, and that for the shared decision-making as well, as Sarah's, because that's what it boils down to. In the end, you have to empower women to take care of themselves so that they can take care of others.
And as somebody who works in education, in continuing education in this case, I can reassure you that there are many efforts underway to hopefully accomplish exactly what you just mentioned. So with having said that, I wanted to thank both of you for your participation today. I think it was a great discussion. And I wanted to ask our listeners to please tune in to our next episode. Many more exciting things to come. And thank you everybody for listening today.
Thanks for joining us. Tune in next week as we continue our journey to amplify the voices of women leaders in pharma and medicine. Hear From Her is brought to you by Medscape Education. Please subscribe to Hear From Her on your preferred podcast channel and follow us on LinkedIn. Until next week, remember to lift as you rise.